mo didibdibin ang iyong problema kung ang iyong problema ay ang iyong dibdib? Dito, sa Barangay North Langhari, Taguig City, nakatira ang isang 14 anyos na si Bernardo. Ngunit, sa likod ng kanyang matatamis na ngiti ay ang isang problemang gusto niyang alisin sa kanyang dibdib.
Hindi ko lubos na maisip na hantong sa ganun yung dibdib ng anak ko. Kasi nung maliit siya, akala ko normal lang. Yung may lubog.
Minabuti ng aming team na ipakonsulta sa isang espesyalista si Bernardo. Sa nakikita kong kalagayan ni Bernardo, meron siyang tinatawag na Pectus Excavatum. Pectus Excavatum, also known as sunken chest or funnel chest, is the most common congenital chest wall deformity characterized by the excessive depression of the sternum. Accounting for approximately 90% of cases, it occurs in up to 1 in 300 births. The opposite deformity of Pectus Excavatum is known as Pectus carinatum or pigeon chest. Although usually asymptomatic, the disease becomes much more noticeable throughout adolescence when bone and cartilage growth is at its peak. Aside from symptoms, the detrimental impacts on normal psychological development should not be overlooked because they can have major consequences for affected children. According to the Royal College of Psychiatrists, teenagers experience anxiety because this is the most uncomfortable stage of their development. Teens are subjected to a variety of external and internal challenges throughout this period. Due to the appearance of the chest, patients with Pectus Excavatum may suffer from low self-esteem, social anxiety, and stigma. There is no known cause of Pectus Excavatum, but it is more common in boys, can sometimes run in the family, and is due to extra cartilage growth around the sternum. This can also be associated with other health conditions such as Marfan syndrome and Poland syndrome. Typically, the lower third of the sternum is much more involved and the upper third may appear fairly normal. A compensatory anterior flaring of the lower ribs at each costal margin is also common. Mild cases of Pectus Excavatum may not show any symptoms. However, moderate cases may show shortness of breath, fatigue, and decreased physical endurance. And in severe cases, the sternum may compress the heart and lungs, causing chest pain and decreased lung capacity. Patients appear to produce an anterior curvature of the thoracic spine with the shoulders slumped forward, which may be a subconscious maneuver to hide the chest wall abnormality. Such spine orientation appears to increase the Pectus Excavatum and to result in spine disorders caused by poor posture and insufficient spinal support. Pectus Excavatum is diagnosed by a thorough health history and physical examination. Diagnostic imaging tests such as chest CT scan is used to get detailed look on the condition. On CT scan, the diagnosis is evident, with the degree of deformity and mediastinal displacement being severe. The Haller index is used to assess the severity of the incursion of the sternum into the mediastinum. Significant Pectus Excavatum has an index greater than 3.25, representing the standard for determining candidacy for repair. Cardiac function and morphology can be easily assessed with non-invasive methods such as echocardiography. Unless the patient is symptomatic, echocardiography is not mandatory in the workup of patients with Pectus Excavatum. However, if Marfan syndrome is suspected, echocardiography should be performed to evaluate for possible aortic root dilation. Some other tests such as pulmonary function test may be used to evaluate the pulmonary volumes, ventilation, and exercise tolerance. The shortness of breath upon exertion in patients with Pectus Excavatum is primarily due to the decrease in pulmonary reserve. Although the condition is not life-threatening, no non-operative management strategies can correct severe Pectus Excavatum. Patients presenting with Pectus Excavatum with cardiopulmonary impairment should be considered for surgical treatment. The most common goal of Pectus Excavatum surgery is to correct the chest wall deformity. This is especially relevant in teenagers because the appearance of the chest can cause major problems with body image and self-esteem. 2 surgeries can be performed for anatomical correction and to also increase lung and heart capacity. First, let's discuss Ravage Technique. The Ravage Technique is an invasive operation that is carried out under general anesthesia. The treatment takes approximately 90 minutes. It entails making an incision across the chest and removing the cartilage that is causing the deformity. The cartilage covering is preserved and the sternum is subsequently placed in the appropriate position. A small bar is then put beneath the sternum to hold it in place. Over the next 4 to 6 weeks, the cartilage will grow and hold the sternum in place. To prevent fluid accumulation or lung collapse, a small drain may be placed at the procedure site. These supports are removed after 6 to 12 months. The other surgical option and perhaps the primary surgical intervention is the Nas procedure. The Nas treatment is a two-part minimally invasive operation in which the sternum is pushed out using a temporary metal bar. This metal bar serves as a brace, allowing the sternum to reform into a more proper position without breaking or cutting any ribs. The first part of Nas procedure is the bar insertion. This process takes approximately 2 hours. The patient is put under general anesthesia and given a thoracic epidural to relieve pain while recovering. 3 small incisions will be made on the patient's chest wall. 2 1-inch incision for the bar and a 1/4 inch one for the camera. The bar is then inserted between the ribs, brought in front of the heart and lungs, through a thin area of connective tissue under the sternum and through the other side. After the bar is positioned, it is rotated into place, pushing the sternum out and corrects curvature. 2 metal bars may be needed to patients with severe Pectus Excavatum. Then, a metal stabilizer is placed on one side and absorbable sutures on both. Over several weeks, the body coats the bar with a thick sheet of fiber, securing it in place. Depending on the age, the bar will stay in place for 2 to 4 years. During this time, the cartilage that was bent into place by the bar reforms into its new position. This stabilizes the sternum, so once the bar is removed, the sternum stays in place. Most patients stay in the hospital for 3 to 5 days after surgery, and they can return to school after 1 to 2 weeks of being off their pain medications. After 3 months, the patient is able to resume full activity. The normal post-operative follow-up for Pectus Excavatum correction consists of outpatient consultations with the pediatric surgeon 2 to 3 weeks following surgery and at regular intervals for the next 2 years. It is advised that patients be monitored at least every 3 to 6 months to ensure that they do not develop any anterior protrusion of the chest as a result of too much pressure from the pectus bar. Following surgery, patients are reminded of the need of maintaining good posture. Slouching and hip bending are not permitted during the first 1 to 2 months after surgery. As post-operative pain and mobility improve, regular activity is permitted. Heavy lifting or anything weighing more than 10 pounds is prohibited for 1 month after surgery. The second part of the Nas procedure is the bar removal. This procedure only takes an hour to finish. In bar removal, the stabilizer is removed and the bar is carefully taken out. The majority of patients will only require pain medication for 2 to 3 days after the bar is removed. After 2 weeks, the patient is free to resume normal activities with no long-term restrictions. The Nas technique produces the best results in children aged 12 to 16. This operation, however, does not fix the flared ribs. Consultation with a physical therapist before or after surgical treatment of Pectus Excavatum is regarded as an essential aspect in successful recovery. The physical therapist assists and instructs patients on proper stretching techniques and exercises that will help the patient recover. Furthermore, the physical therapist can help patients establish appropriate posture, which is critical for a good functional and cosmetic outcome following surgery.
Sabi nga nila, huwag mo masyadong dibdibin dahil may likod ka pa.